Well, thank you. And thank you to all the presenters and the chance to learn here today, truly. And if you're in this room, you're a heck of a great person. Not me, but other people here are great. And yet, as Deb pointed out so well, we have done some not so great things. Not the new phrase, right? Like, it's not okay. Well, yeah, some things are just not okay. They're wrong and unethical and challenge our very professional identity and human identity. So in this way, I think we're birds of a feather here. My name's Steve Martin. I'm the same guy who spoke earlier. Just maybe a little wiser. I was able to gosh, I don't know where to start. This is a variation of a talk I gave at ASAM in Dallas. If you were there, you can take over if you want to. It turns out when you give a talk on the history of something, like, it's hard to sort of like change a lot unless you want to do like a 1984 version. Like, and in this different history, these other things have. But so you're sort of limited that way. But it turns out that there are new wrinkles in this, and I can promise you two things with this talk. Number one, we're going to start with a brand new start that's really good. And number two, I'm going to finish the talk, thanks to Sam and her colleagues, with a bombshell. B-O-B-M-B-O-M-B, bombshell. Yes. Okay. But I also, in the interim, will let you leave ASAP. Okay. So I'm going to put on my Pittsburgh cadence of voice, and it's going to be very, very fast. Okay. So basically, does drug testing treatment help or hurt? It generally does not help. And it does hurt. So last time I took an ethics class, like, that's not great. Especially when it's compelled. Right? So not great. So my views are my own, so that I can, try to bring home a paycheck or something. I don't know, or delist my phone number. But these are the learning objectives. We're going to do a lot of good stuff. It's going to be good. Okay. I actually have to bring this. Yes, it is. Okay, here we go. Ruth is going to lose it, and she sees this one. Okay, you ready? So I was born in 1969. Yep. I was born in 1969. Do the math, how old I am now. But first year Sesame Street, which I think has really been a cultural icon for so many reasons in the US and worldwide. It has had a global mission for a long time. So one of my favorite games on Sesame Street is one of these things is not like the other. And here we have Kermit on one of these things is not like the other. I don't know how there's a song for that too. But so I'm going to ask if anyone wants to volunteer. Which of these things, we have a hammer, pliers, saw, and a shoe. Which of these things is not like the other? Shoe. Let's see. Hey, all right, shoe. Okay. All right. See, it's late afternoon, but you're still doing really well. Okay. We have Cookie Monster here, back when he was allowed to eat cookies. And so which of these plates in front of Cookie Monster is not like? One has 3 cookies. Yes. Ooh, ding, ding, ding. Okay. And then another one here. Here's Gordon. And this one's, I hope it's not too hard to see, looking at different carrots. Which of these is, different than the other? One, he's actually pointing to it. Yes. Okay. All right. You guys are like, you got this thing going. Okay. All right. So I'm going to show you, we're going to the next slide. Here we go. How about, here's one thing, a harm reduction approach. Oops, here's another thing, trauma-informed environment. They're sort of alike. Here's having flexibility and individualization of care. And here's a toilet. Which of these things is not like the other? It is full Charmin. It's good stuff. We're not barbaric here. Yeah. Uh, which of those things is not like the other? The toilet. But I thought we were supposed to do low threshold care. And it seems like those first three things are low threshold care, but maybe the last one isn't, and we forgot about that, and that people really don't like to be compelled to do things that they experience harm with. And yet somehow that's gotten a pass, right? That's grandfather in the drug testing, because just because, right? Just because. And this toilet picture, thankfully, comes from I'll show you the larger toilet picture in a second, but this is the Greek. I'd read it, but I'm a little rusty. But from Hippocrates, basically you need to do two things in the medical profession. You can either help or you do not harm. And with drug testing, we're not helping. We can only harm. Ergo, we're not following this very ancient command. To bring it to more contemporary times, you can't say that you're a program that provides choice to people, then take the choice away from them. If we're truly a program that says other drug use is not an issue, then we must follow that through. Because there is some serious cognitive dissonance, my friend, going on with our mixed messaging in the field. Let's not just say it and be full of S word. Shit, it is what it says. Let's not call ourselves harm reduction and then be abstinence-based thinking. It doesn't make sense. Whoa, let's just rip the Band-Aid off, because I'm telling you, you take any philosophy major looking at this or ethics major, they'd be like, God, I think you have a problem where you're like this low threshold people, but now you're compelling people to pee into a toilet and you're watching them. Those two things don't seem like they go together. Maybe it's affecting people's care. Just a thought. You might want to know that. Okay, so this is the more complete picture, courtesy of Dr. Shaw. This is a Boston metro area clinic. And that's not just a toilet with two-ply paper, but that is a peephole that people watch patients pee in all day long. On the other side of that little black peephole is an eyeball, watching someone pee and collect their pee for testing. That to me seems not so low threshold. And yet it is the natural extension of absolute power corrupting absolutely. And there's no way out of that one. Because once you start walking down this path of any testing, then you're like, well, I have to make sure it's the right person. I have to make sure it's not adulterated. I have to do this. And then 5 minutes later, you've cut a hole in the freaking wall and you're watching people pee. Like, that's not cool. What if it was life-saving? Then you could make an argument. Maybe it's life-saving to watch people pee. But I'll take you through some data today that I think will show that that's not true. So instead of like a seminal study, let's say like warfarin for atrial fibrillation, for aspirin. Oh, how about vitamin C for scurvy? We don't have those studies like the study. We have other interesting studies. One of them from East Berlin. So what you want to do in East Berlin after World War II is be careful that there are not many weak-willed persons who are addicted. And in order to discover addictions, you have to create a test that they will all need to urinate for, so that you can put them in a special, happy little institution place that they live in for a long time. And this is the exact antecedent of what we do today. What we do today goes back to literally population control in East Germany in 1946 to 48. Because the Germans were freaking amazing organic chemists. I mean, the same organic chemists gave us aspirin and heroin in the same year. I mean, that's a lot. And methadone. That gives methadone as well later. And oxycodone. Oxycodone is like 1935. I mean, talk about old school, right? So they're pretty good at that stuff, but they're also really good at testing stuff. Except they realized these tests didn't really work that well. Like there were some false positive problems that they actually spoke about. But I'm going to jump ahead now because we crossed the pond, crossed the Atlantic, and now we're in 1960s in California and going back to mandated courts. You could absolutely join this wonderful mandated court system. And under the supervision of a special chartered parole authority, you're closely supervised after release. And failure to remain drug-free resulted in a return to the facility for further treatment. Treatment there, I think, is in quotes, but you get the idea. So again, not like a study like, again, take vitamin C, don't get scurvy, more like we're controlling a population that has a medical condition. This, I mean, as the history here is interesting because Vincent Dole of Dole and Neiswander was actually a professor of metabolic care, metabolic medicine. Metabolism was his specialty, and he thought of addiction as a metabolic disease, actually, is the title of one of his papers. And so he was very adept at making testing assays at Rockefeller. And this paper is from 1966, even before the publication of the papers he would do later on methadone. So they're already looking to see what's going on. And this is not just for opioids, but tranquilizers, amphetamines, and barbiturates. And then if we move across into Chicago, Jerome Jaffe, who was the first head of what became ONDCP, and trained with Vincent Dole, built his own lab at the University of Illinois, the first methadone program in Illinois, also built a machine to test people. Not yet have we seen the study, the randomized study that shows this improves people's care, right? We haven't, just be clear about that. We're not there yet, and it won't come either. It's not going to happen. Okay, so now we're at 1968. Then that is an interesting time in the United States, 1968, a terrible, tragic year. But in 1970, now we already are having testing schedules for methadone maintenance. That's a pretty evidence-free recommendation to make. So again, there's been no study to show it helps people, but we already have a schedule for doing it. And in medicine, just be very wary when that happens. When you can ask a question in medicine, say, hey, where did that come from? And people are like, we've always done it this way. You're like, then your antenna should go up and you should talk to someone quickly before you get sucked into the system. And then we have Nixon R period in 1971, and what became a seminal moment for testing at scale, where Vietnam veterans who were in Vietnam, not yet veterans, people in Vietnam, soldiers, could not leave Vietnam to come back to the United States until they passed the urine drug test for heroin. And the thought was they didn't know, they tried very hard, I don't mean to take your time on a beautiful day, but bless you. They didn't know how many soldiers had a dependence on heroin. And if you really torture, you can sort of see like they didn't want 70,000 people coming back with dependence on heroin. And now we're back in the States and there's no market, or the market's going to grow very quickly. So that was the best intent of this work. But nobody came home, nobody. If you tested positive, they kept you around for 3 days until you tested negative, okay? That was the treatment. This was a course called Operation Golden Flow. And a friend of mine, Cindy Grandy, has actually gotten on eBay and got me one of these patches, which I can't wait to wear. I'm gonna wear it to clinic, like on my white coat. Operation Golden Flow for the cause. Okay. Well, if you're wondering, like, why do we do that screening test? And then there's this confirmatory test, and Steve Martin's a geek, so he can't help but talk about this. This is from Vietnam. So it was actually hard to get voltage to be just right at these screening centers. So they would do a free radical assay technique. If it was positive in the second highlight section, the Army insisted on reporting only confirmed positives, which were lower in part of technical problems with the confirmation procedure, but the screening procedure also had difficulty. So they would do a screen essentially like what you do today, an immunoassay, and then they would do GCMS if needed on all positives. That is why we do what we do today. But at least the Army forced them to check all freaking positives with a confirmatory test. And lo and behold, I think everyone's doing that, even though that's what we're supposed to be. And patients don't know that we're not doing that. Okay, how about we go right straight from East Germany to California, to methadone, to Vietnam, and now we're coming back. And what we've learned in Vietnam has implications for a methadone program. So not only do we not have a vitamin C study, we actually have a study of coercive screening for an entire population that we're going to transplant from Southeast Asia in the military to civilian methadone programs in New York City. That's the best data we have for using urine drug testing. Bless you. And once you start doing it, you can do lots of studies because you never ask why. You don't have to worry about the why anymore. You're just like, well, how many studies do we have to do now? And in this case, you have to do random sampling 1 day in 5 to allow a 95% confidence interval. So you can get very technical in a hurry. You can read about the molecules. You can get really deep into this stuff, but you just didn't ask why. And I think we need to ask why we're doing this. So one person who can say why is a lady who was interviewed by Lev Fasher for his SPAT series on methadone. And if we have access to the internet, I will play this without any hitch. Without any hitch. Dun, dun, dun. Dun, dun, dun. Dun, dun, dun. Dun, 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 dun. I had the same problem at ASAM. It's like my bad dream is coming up in me. I want to move this thing over there. I want to move this thing over there. I want to move this
is
one.
what I do. I've been trying to be healthy.
I want to move it right
possible
now.
Since
She
I've
is
been
so smart. She's
trying to get my life back together.
How am I going to do that?
Tastes like mushrooms.
And that's what I had to do.
No, it tastes like coffee.
Beg someone to help me.
Rebecca Smith is in recovery from heroin
Hi,
addiction.
Mark Barnett saying
Play
he
it?
promised
Okay.
you.
Left toward Chrysler Drive, I-75.
Watching it.
When the
I
gunman
got away
shot his
from
way into
all of the riff-raff people. I
Now
got
to
rid
turn
of
it all
all
up,
my
it's-
phone numbers that I had. Anybody, any dope man or any person that I owed money, I made sure I paid them off so they wouldn't have no reason to call me to say nothing.
She's so much better than I am.
So
Okay.
that was it. I washed my hands of that. I went in.
So I'm sorry. So she's in a methadone program in the Detroit area. There's interestingly no public transportation in Detroit that really works. So she has to take an Uber each way. That costs money. She has had take homes, and she's had her life made so much better. I mean, you really must listen to this because of my stupid video, or we'll stay after and have like a watching. But one day she goes to her son's graduation for high school and she has a glass of wine. The next day she goes and she gets her take homes for 14 days, 13 days. The next time she goes to the take homes, she's given no take homes because her urine drug test showed alcohol. Her take homes are taken away. She loses her job. She has to take Uber every day that she can't afford. And so this is actually not a case of the system not working. This is actually the system working perfectly. The system worked perfectly for this methadone program. It was testing for alcohol. It had a no tolerance policy of any other substances. She was found to have this other substance, and she suffered the consequences. This is a contemporary example of someone suffering harm from testing in the US. And ASAM, MASAM, Choose Your SAM, I'll say on the ASAM side, I think ASAM has aided and abetted this. And I say that I'm not speaking for the Quality Improvement Committee, but I'll tell you, you read the studies, there's no studies to support the guidance that we're using out there. And what would you say to Ms. Smith? You'd say, Ms. Smith, God, there's just no evidence, but we really thought it was great coming from Vietnam and East Germany. And I'm sorry that it just didn't work for you. It's been over 5 years, she said, and you're going to do this to me. You're all doing stuff like this to make me go out there and relapse. It's like you don't care. 5 minutes with this is just make you go crazy. And so it makes me go crazy. Okay. So we could go on. I mean, this happens all the time in the US. Witness drug screens, humiliating and harmful. How about just speaking to our colleagues earlier with concerns for maternal health? They've really taken the lead, thankfully, in saying, what the hell are we doing? What in the hell are we doing with this? First of all, just to get the data, and secondly, the data are wrong often. We're doing absolute harm. I love this title here, We Separated at Birth. I mean, it's a terrible, tragic title. This is 2024 at ASAM. And even NIDA, my hat's off to them, are asking questions. Stephanie Weiss, who works in their research lab, noting that a urine drug screen can have life-altering consequences. So I would just say for folks that's, we all practice with patients here. What I'm going to do is I'm going to give you a point of care drug test. And the consequence, if I find something in that test, is that you're going to go to jail. Let's say it's a drug court. So I'm gonna give you, every one of you, a drug test, point of care, and I won't interpret it. What I'm gonna have you do is I'm gonna give you 100 clinicians, and you can randomly choose one of them to interpret it for you. Just do that, or a family member. Just think of your son or daughter, brother, sister, mom, just a random clinician. Just have them interpret that test, and you go to jail or you don't. And if you think that clinicians are really aces at interpreting this, that shouldn't be a hard choice, right? Like, everybody knows what they're doing. How many people think clinicians are super good at interpreting without fail or error drug testing? Not very good. This is the worst combination of testing, sir. I agree. This is a high stakes test with crappy interpretation. That is not in the 2x2 box you want to be in. And the idea that we're going to make it low stakes test is really ludicrous, as Mrs. Smith saw. And so we come here to sort of the ethical considerations, as we did in terms of pregnancy as well. Turns out that some people find this is an offensive, anti-therapeutic, profit-driven, even constitutional practice. I don't want to have a lot of those practices that I do. I would prefer not to have a lot of things that look like that. How about eating a poppy seed and having your baby taken away? Because clinicians are fucking idiots. They really are. Record away, because I'm sorry, this is F-bomb territory right now. I'm sorry. But this is so sad. We should be humbled. We should be enraged. And we cannot be complicit. How about what happens, let's say if you have a drug test and there are consequences. Are there any consequences, do you think, of being terminated from a program? I mean, you just go skip down the road and, I'm glad I don't have to go there every day anymore. Oh, I'm sorry. Oh, that's right. You die higher rates. I forgot about that. But thankfully, you did follow the rules, though. How about people say these strange things like they don't like people watching them or seeing them pee? I don't know why. It's so strange. Being on tape, people are taped. I think that is an invasion. I think it constitutes an invasion of privacy. How about you couldn't go? Just sort of stayed there, had to drink those 8 cups, just doing what you can. I have a patient who will never go to methadone. He can't go to methadone because of sexual trauma. What am I going to say to him? Huh? How about violations? They told me, you're not supposed to be drinking. They gave me a couple opportunities. This is from 2024. I was honest with God, I was on a golf course. I had some 1 or 2 or 3 White Claws. The patient had previously benefited substantially from buprenorphine and described struggling mightily with cravings and withdrawal after the imposed discontinuation. They told me you're not supposed to drink it. Here's another one. Their clinical policy is you shouldn't drink when you take buprenorphine. Rather than cease drinking entirely, he cut down. I was honest with them. Please let me have a sip of alcohol, Nonetheless, the clinician stopped prescribing buprenorphine. 2024 study. This is not some esoteric thing that's happening around the corner in one place of the United States. This is common practice. And folks, if we have any connection with academics, we've got, or institutional societies like MASAM, we've got to speak out, I would hope. But you have staff saying, we're not going to do that anymore. These are Canadian staff. Let's try and build a relationship. Let's try and build a relationship based on trust and respect. This is when I'm watching you pee, right? It just seemed ludicrous. Yeah, I think so. How about the Swiss? We always talk about the Swiss are doing such great work. Those Swiss make those great chocolates and watches and stuff. But interestingly, they love things being on time. They're very assiduous and meticulous, really. They don't do any drug testing. None. And as the person here said that, why would we do something like that in the blue, which is very restrictive, and people could be kicked out of the program or disappearing because they can't comply with the regulations. I think we would lose a lot of patients. They would die. Oh. what country is doing that? I can count one. So if you visit Australia, no testing. If you're coming from the US and someone who's been on methadone here, you get to the point where methadone has been life-changing in the bottom paragraph. I can no longer abide the cruelty with which this medication is dispensed, and I made a conscious decision to walk out, take my chances, finish tapering off opioids with drugs I buy in the illicit market. I'm done trading my dignity and safety for safety. I think this constitutes harm. I don't think we have to do any studies. I don't want to do any studies. I don't want to hear the word study. The studies have been done. Harm is apparent. This is highly face validity harm. Our colleagues at the National Survivors Union have written the Methadone Manifesto, weekly drug testing, despite regulation that only needs it 8 times a year. More is better, I'm sure. And the patient themselves has to consult a false positive. Do you know the kind of it is, as I mentioned, clinicians have no idea what they're doing. You have to get a separate degree basically to understand these tests, I think. And it's humiliating. These are, again, our colleagues of the National Survivors Union. How about some harm? I'm just so saddened that people haven't looked at it objectively, but our folks up in British Columbia have. The more frequently you test, the more often you leave care. Okay, how about clinicians? This is my favorite because I just love skewering us. Immunoassays are tough, so you really need to do confirmatory testing. How many of the probation officers are doing confirmatory testing with GCMS? All of them now. How about 5 years ago? None of them. Anybody want to be someone in parole 5 years ago? How about psychiatric? This is my other favorite from Joji Suzuki. Residents and fellows score poorly in the knowledge, but they're really confident. Sort of the classic line about surgeons, right? Sometimes wrong, never in doubt. But I don't want someone like that having ownership or commanding control over my life or a family member's life. We'll sort of move ahead here. These are saying roughly the same thing. How about policies? There are no national mandates for testing for buprenorphine. 0. And to my knowledge, in Massachusetts, there aren't. In Ohio, you have to do it 2 times a year. So there are state regulations, but at the federal level, there are not regulations about having to test. False positives can halt treatment, as we mentioned, or impact parole or child welfare cases. How about the evidence? Let's just go right to the evidence. And Robert DuPont, who really started some of the methadone work with the DC jails back in 1969, 70, that came to the attention of the Nixon administration as a way to combat crime, described drug testing as the technology of addiction medicine. And I don't know Dr. DuPont in any way, but I would say, Dr. DuPont, that's not a technology that I think works so well. Not working so well, that technology. Because here we have in 1976, we have problems with the testing already. How about if you wanted to put in PubMed, drug testing, and substance use disorders, and randomized trials? You get, oh, wait a second, you get 0 results. What else do we do in our work that has such high stakes for people that you would get freaking 0 results for studies on it being done? And this is at scale where people are harmed and die because of our decision making. How about if you want to put in drug testing and randomized trials or review or even systematic review, you get 11, none of which are actually relevant to our question. How about few studies with poor quality have assessed the value in UDS and managing patients? The value was not clearly indicated in these studies in 2014 and 2019. This is a great one, right? Of the 60 potentially eligible articles reviewed, only 1 3-arm randomized open-label trial comparing weekly and monthly UDS tasting with take-home met our inclusion criteria, and it wasn't a great study. It was like so 1 study. I think that's great. So we can say that we have some problems with the practice. How about there's increasing confusion? So this again is not what you want as a patient, right? Testing rates are likely to be determined by local practice patterns, provider discretion, I don't even know what that term means in that context, and a variety of patient-specific factors. So in Tennessee, at least 12 tests. So basically, you're a prisoner of the 10th Amendment. So all of these choices are left to the states, just as someone suggested other decisions should be left to the states recently. And boy, that's where I can't wait. I was really hoping all those decisions be left to the states. But it turns out that that's sort of nice if you live in Massachusetts, but we cannot enact policy based on Massachusetts, and we must not. It is a disgrace to have this in place. One Canadian guideline says that they vary province to province. Like it's the same problem. You're never going to standardize it. Okay. This is the one that makes me sort of pretty sad because these are a group of addiction medicine specialists. When they were looking with NIDA at a new quality of life outcome, they had 2 rounds of Delphi model. You know, you get together, put your heads together. It looks sort of scientific because you call it Delphi, and the Oracle came from Delphi. It's like a Greek thing. Okay. So quality of life had consensus, but in rounds 2 and 3, the consensus shifted to 48 and 50, and they got rid of the quality of life one because that's probably not important, the quality of life for people. I think it's just whatever, like whatever. Okay. How about urine toxicology? Like it had 84% in round 1. Whoa, but it fell to 50 and then 41% in rounds 3 and 4. So the group determined that the initial high ranking merited inclusion of an observed urine test as a quality measure. That's not rigorous thinking. And it has a tremendous amount of harm for people. So the proposed metric is, in the past 21 days, they provide at least 2 urine drug tests in different weeks that are negative for opioids. That is now the NIDA standard of care for research, based on the conversation in the preceding 2 paragraphs. How about the French? In the second section there's far less urine testing in France for people, which helps build trust. We've been so gracious to the French about their buprenorphine stuff, and we sort of pick and choose what they do. Like, oh, we'll make it easier to prescribe buprenorphine, but we'll have a very high stakes test that we'll do, and they don't do it, and somehow they have better results. Or I'll skip this. I'm going to come back to just a classic article. When should you order a test? Will the test result in change of my care for the patient? This is freaking basic level clinical epidemiology, clinical decision-making 101. I did a test. Will it help me make a decision? And in 2024, what are these tests deciding for us? In 2024, one of these things is, I'm gonna get a t-shirt like that. One of these things is not like the other, I'd have to say. So turns out when you have a pandemic, it's harder to test. And then you get another series of articles that are sort of have some cute names. Down the drain, reconsidering routine urine testing, considering the harms of our habits, reassessing the role of routine. And yet we still have Ms. Smith penalized in 2024. How about guidelines? Well, the tip 1, the tip series from NIDA, tip 1 is the methadone treatment guidance from CSAT in 1993. That's the first time that guidance for drug testing is referenced, and it has no evidence. And so we come to number 13, which will be the ASAM renewal of guidance, which is currently underway from 2017. So in about a year or so, we may have new guidance. And I'm not speaking for ASAM in any way. And yet, do we need to really wait for that? Do we need to wait for more guidance that's based on no studies that show benefit? And I've talked with folks deep in this work, and their first question was, there are no new studies since 2017 of benefit. And the evidence for harm continues to accumulate, so why wait? I don't like the idea of continuing to do harm while I put together some freaking guideline that looks pretty. Okay. CFR, wait for the bombshell still to happen, and then you get to go home too. So the bombshell is like it's like here. It's right behind here. You can't see it. Only I can see the bombshell. Okay, so this is CFR. Like it's pretty much in law. Got to do those 8. You've got these point of care tests, How many tests in medicine have this sort of combination where they're cheap and fast and they're really good? Glucose, very nice, but glucose has a standard deviation of like 40 to 50 points sometimes. Pregnancy test is the what, like prototype, right? And then you start to push on it. For me at least, I can't think of many things beyond a pregnancy test that are like unbelievably great operating characteristics of negative and positive predictive value. Like, it is really awesome. I've had patients, they do 4 pregnancy tests, they're all positive. You know how I would do that too if I were, I would swear, right? But they're all going to be positive, at that point. So, but that's a very unusual test. Most tests, you don't do it that way. You're not like, here's your HIV immunoassay. Steve, you've got HIV. We're going to start treatment, we're going to get treatment underway. And I just want to know you have HIV, and that's, hang in there, okay? That's what we did though at BMC back in the day, point of care testing. When you have a low, even BMC, when you have a low enough baseline population, your false positive rate will outweigh your true positive rate by about 10 to 1. So you're guaranteed to have 90% of people or more get the wrong information for a high serious disease. So we don't do that. And I think it's worth thinking about other things that we don't do because of testing. And this is where, I'm throwing everybody under the bus. Really, this is SAMHSA under the bus, okay? Tip 63, because these must be easy conversations to have. Scenario, a provider discusses urine drug testing with a patient being assessed for ODD treatment with a medication. Provider, when we assess patients for medication for opioid addiction, we always check urine samples for drugs. Patient, I'll tell you if I used, you don't need to test me. Steve Martin, thank you, I really appreciate that. The more we can talk about what's going on with you, the more I can help. I'm not checking the urine to catch you or because I don't trust you or I want to take away your take. No, I trust you. I can see how motivated you are. I don't trust the addiction. Because I know how powerful addiction can be too. To monitor your safety on medication and help determine what other services you may need, because I'm so beneficent, it's important for us to at least test you periodically and discuss the results. Does that sound okay? Patient, yeah, that makes sense. Tip 63, like I don't do that. Okay. Just as they did early, our colleagues in obstetrics and gynecology took the lead in providing a lot of buprenorphine care early on, thank goodness. And with their declaration in 2017 that they're going to stop doing testing without a patient consent. But we're really different than all those people, I guess. I don't know what to say. Maybe only in pregnancy we should do this because other people they don't really have high stakes outcomes. We should just keep it limited to GYN and obstetrics. But I don't think that makes sense either. So we've had, again, activity in the state as we were discussed with earlier today so well. The hospitals will now require written consent for toxicology testing. How many folks have given written informed consent for toxicology testing where we work? Part of their sheet, I'm sure, it says it buried somewhere. Anybody read Foucault? Anybody? Foucault? Yeah, no, I'm not a big fan of medicalization in the birth of the clinic and the panopticon that happens with surveillance. And it turns out that methadone shares many of those attributes. And that the Europeans have written the most robust refutation, where European addiction specialists have described this as an unethical behavior. So this article presents viewpoint previously published in French and French German papers supported by Swiss associations in line with a patient-centered approach. Recommendations include removing the obligation of any remaining legislation and limiting tests to situations where the person in treatment has requested them. Do we need a whole guideline when they've already put it in this one paragraph? If it helps a patient, let it help a patient. If you're like a super contingency management patient, like go for it. Knock yourself out. Have as many as you'd like. I have a patient who does that every week. Every week, I write a letter to her mom and I email it saying that her alcohol and her buprenorphine level are fine, her urine tests are fine, so she can see her kids. I'm all for that. That's fine. She's all in on that and agreeable. But the European Court of Human Rights actually considered this a forced medical intervention. And because it's not given freely, the patient is given no alternative but consent to OAT as a package. No longer the goal of OAT urine tests to ascertain abstinence become irrelevant and even counterproductive. Again, if anyone has that study that shows huge benefit from drug test, please let me know. I mean, I see all these hands up, so I'll get them later. But it's an embarrassment. We're academicians. I mean, this is crazy town that we've had this momentum from the 1960s affect our patients. However, no evidence suggests any benefit of urine testing in this context. Europeans 2024. Therefore, it appears unethical to impose urine tests in a vulnerable population that is particularly likely to disengage from healthcare. Anyone agree with? I have a tattoo that says that. I mean, that's the work right there, right? Okay, I'm about to get off the stage. Why do people want to stay in their low threshold butte program and their bridge program? Maybe because the other programs are a little scary. Yeah, I love this study. Noel Martinez did a great job here. Oh, we have a bridge program. It's really patient-centered. Why don't you go to this other scary program where they're going to test your urine all the time? Oh, that sounds great. I can't wait to go there. John Lepley, a good colleague from the osteopathic addiction medicine, has already written his colleagues about stopping doing this and eliminating reflexive urine testing. In fact, we're pretty limited in who's doing this. Not Switzerland, not France, not Portugal, not Australia, Canada, weak, don't do it that much. The World Health Organization says not to do it, ACOG says not to do it, and thankfully John says not to do it. Not a lot of good, I think Iran does it, maybe in China, but they're good, they're good people. They're good people too. How about, oh wait, here we go. Oh, how about if you had a study on ethical addiction treatment from the American Society of Addiction Medicine in 2024? And this one said, historically, we've had common paternalistic and moralistic treatment methods, and the ethics of medicine and public health call for upholding informed consent. Oh my gosh, ASAM said that? Wait a second. What else do they say? Rarely includes how these coercive strategies are perceived or experienced. Oh, wait a second. That makes no sense. Ensure measures are patient-centered, accurately reflect positive patient outcomes, cost-effective, anticipate and mitigate adverse or unintended costs. Whoa. I didn't read that last year, but that's official ASAM policy 2024. And now the bombshell. Are we ready? You guys are like, I feel it. I'm feeling it. Okay. This is it. Take this home because this is gonna be a shit show. I say that in a good way, but it's gonna be a shit show. This is new official guidance written by Sam and colleagues, thank goodness, that's already been voted and approved by ASAM and will be online this coming week. Patients have the right to refuse any treatment service, including drug testing. Treatment programs should not attempt to coerce patients into participating. Admission and discharge decisions should not be based solely on drug test results or a refusal of drug testing. So I would like to know what CSAT says about when someone refuses their 8 tests. And I'll tell you what, once the ACLU sees this in print, all those places are getting sued. I'll join in. This is nuts. And this, thank goodness we have this. I'm clapping for this. Sam, thank you and your colleagues who wrote this. Do we want to be right or in a relationship? Right? Is that what they say? Yeah, it's time to give it up. Give it up. And we cannot have both ethical treatment and forced treatment at the same time, it turns out. And with respect, right? With respect. I'm not saying two things in different ways, but in this way, this is a common practice. I am saying two different things. I want to keep people alive though. And I think in this way, when you force people to do things, you make it less likely for them to be alive. Okay. So does that consider a bombshell or not? Like, can you imagine your program going back to your programs and saying, oh, just want to let you know, patients can refuse any tests. Oh, that's great. We can't wait to, that's great. We'll just change that. No problem. We'll save us a lot of money, a lot of time. That peephole thing, we can put the wall back where that peephole is. Don't need to use that anymore. How many people think their program is going to be a little shocked that patients actually will have agency over the kind of care that they get? Yeah, maybe a little bit, huh? This is uncomfortable. Uh-oh. Okay. And this is the look for this in your inbox in the coming week. ASAM clinical considerations for engagement and retention of non-abstinent patients in substance use treatment. To me, again, just Steve Martin, this obviates any need for any drug testing update. Because now we have a patient can either choose to have testing or choose not to have it. That is your guideline. And if you're going to do it, do a really good job. So to finish, I just want to come back to this because I do, make sort of fun of other people. I don't mean it, I'm not a lot of fun, but like, look, you might say, look, I'm really good at this. I could do that. I can do this. I'm good enough to do this. And that may be the case, right? But we don't know that that's true. And you cannot base policy on thinking that you're better than everyone. For example, I think I could be careful with a hand grenade. But turns out there are laws against me owning a hand grenade. But I'd be really good at it. Or I'm really good at speeding, right? Which is not a great example. But yes, so the power does corrupt. I mean, this completely changes our relationship with patients in a destructive way, I think. So let's ask patients what they'd like to do. I think that drug testing is on the wrong side of history. And it happens to be that we're in an endemic pandemic and epidemic that's lethal. So do we really want things that get in the way of people having life-saving care? That seems like a no-brainer. So final takeaways, testing was designed to be a big brother. Testing does not derive from empirical study of benefit. It's outdated, antithetical to our low threshold care is the one thing that is not like the other. Because it is coercive and jeopardizes life-saving treatment, it's ethically questionable. Probably not questionable, just unethical. We'll stay there. If diversion was our primary concern, we would all be testing with oral fluid because people don't like urine. And oral fluid's been around for 20 freaking years. So why are people still using urine? Because it's degrading and because it fits the pattern of control and demeaning. And I would not have learned about oral fluid except it was for Sarah Wakeman describing it in a broadcast in 2014 about a Massachusetts MGH homebrew test that she uses. And the GCMS test, it's oral. When we have patients that we test and they're amenable, our medical assistant pop it in, gathers a milliliter of saliva, pop it out, all done. No urine. No more swimming in urine, like my lab said before. But yeah, I was sort of curious, like, why don't we do something that's better than our current tests? And we're doing urine still. Please do only these things, I would say. An ethical way to proceed would be to ask patients if they'd like to be tested, and if they do, to use oral fluid GCMS, and if not, that we don't test. That's sort of the simple answer. And thank you very much. Thank you. Thank you. All set.